Okay, so we can start. Okay, welcome back to the Theranostics series. Hope you all enjoy the first two lectures and us, starting to see how fascinating and clinically powerful this field really is, right? So today we are diving into really exciting and crucial part of the whole puzzle, and that is nothing but itself the therapeutic radiopharmaceuticals. That is our topic to discuss today. I am just briefing you about the session first, and then we'll proceed with the slides. Okay. So basically, we already understood the basic part of the theranostics, and we already completed the diagnostic aspect, right? So far, we already seen how molecular imaging can help us to pinpoint what's happening inside the body with the help of radio tracer, right? But now we move a step forward from seeing to treating. Okay, so since today we discussed about the diagnostic aspect, and the today's session is totally dedicated to the treating part. Okay, so this is where the thera in the theranostic really starts to shine. So you have probably heard some of these names already before in the yesterday and the very first lecture, that is the lutetium 177 dotatate, 177 LUPSMA, right? Iodine 131. So these aren't just radioactive compounds, but they are precision guided missiles, and that can exactly go onto the target and destroy the cancer cells with the minimal damage to the healthy tissues. That is what exactly it's the aim is. So basically it is very much real in the scenario and already happening in the clinics across the world, including the India as well. And we will start today with an overview of the key therapeutic agents, whatever three key agents which is prominently we are using it in the world as well as in the India. So there we'll see their clinical indications as well, and why these particular isotopes are game changer. So we'll discuss that point of view. Further, we will go deeper into the mechanism of action. So how these drugs selectively bind to the receptor, how it is get internalized into the tumor cells, and exactly how it is damaging the DNA, so okay, of the tumor cell, that we'll see. Also, it's a perfect example of how this molecular biology meets with the nuclear physics. Okay, so I have included a short video also for your understanding, to see the 3D dimension of how exactly this radiopharmaceutical has their role to play. Okay, so and how we are using this to the outsmart cancer. So basically, we will also look at the pharmacokinetic and biodistribution part today. So maybe I think many of you having question yesterday of pharmacokinetics, right? So what is kinetic of radiopharmaceuticals and radio tracers? So basically, I think you don't analyze the brochure correctly, because the third session is dedicated towards the therapy part, and the third molecule of the overall session is dedicated to further the PK. Okay, so there is the pharmacokinetic. Also, we'll discuss about the biodistribution today, because knowing where exactly the drug dose is going, and how long it is staying there, that is a biodistribution, and how it's cleared from the body, it is very essential not only for the efficacy but also for the patient safety, right? So of course we can't ignore the practical side as well. So we will discuss the route of administration as well. The question was there in yesterday, that is how exactly it is being injected, right? So that is the again a part of our third lecture. So we'll discuss the route of administration. Usually it is IV. So we'll discuss that what are the clinical workflow and how it looks like in the real hospital setup, right? So from the cold kits and the radiation safety to the amino acid infusions for renal protection, that is overall discussion topic for the lecture. So finally, we will talk about how we monitor the patient post therapy. That is the last objective of our session for today. Okay, so just like with the diagnostic scan, we need to track how tumors respond using the follow up images. That is monitoring part. You will get it, don't worry. So that is the overall summary for the lecture. Okay, so I'm starting the sharing the screen and starting the lecture. If you have any question, we can solve in between also, in completing the one learning objective. We can have the question and answer. and then we'll proceed with the next. Okay, so without wasting much time, I'm sharing the screen. Okay, I hope the screen is visible. Okay, let's start with the title of our course again to remind ourselves what we are learning today, the future of personalized cancer treatment, Theranostics. Okay, so this is the lecture number 3, which is dedicated to therapeutic part in the theranostics. Okay, so basically you now has the ability to understand that the radio tracers are being used for identification of exact location, okay, where exactly the metabolic activity is happening, and that's what the PET and SPCT is doing, right? And also we have some anatomical imaging technique with us for CT and MRI, for example. So that is aspect we already understood in the last lecture, right? Now we are moving forward with the therapeutic. What is the treatment approach? So obviously we are going to use the same radio pharmaceuticals, the products, the chemicals, the chemical moieties, we can say, for therapeutic purpose. So we'll see in lecture the mechanisms and the delivery. See, these are the 5 points which are the topics for the discussion today. The very first topic is the overview of therapeutic agents. So we know now what is the 177 Lu dotatate, the I-131 iodine basically, and 177 Lu PSMA, right? So basically we'll see the very first part as an overview, which is understandable because we previously discussed these agents, right? Second point will be the mechanism. Now that is very important because it is going for receptor targeting. Also the second step is internalization, that is nothing but the engulfment is happening. And the last step is a DNA damage, and the alongside with DNA damage there is a radiation. So basically that is the overall mechanism we'll discuss in detail with the example of each. Third point, that will be pharmacokinetic, biodistribution, and radiology. Three of these mechanisms are very important as per the patient safety, right? If you don't know the PK/PD mechanisms of any kind of drug, that is, you can imagine that there is no meaning of it, right? So basically for the radiopharmaceuticals also we should know what is the pharmacokinetics behind it. Okay, so what drug does to the body exactly. Secondly, we'll understand the biodistribution, like exactly where it is heading, and we'll see the radiology, what are the radiation effects. Okay, that is our third point. Fourth point is route of administration, like it is IV, but we'll see the exact the video how it is getting administration into the body. Okay, and we'll see the clinical logistics in the hospital setting if you are going to implement these strategies. Okay, so, and the last point, that is a monitoring response to the therapy and the follow up, what needs to be checked after initiating therapy or after completing the therapy. So that is the topic. These are the topics to discuss in the session, and these are the learning objectives. So by end of the lecture you will be able to understand the mechanism of action of the key therapeutic radiopharmaceuticals which are used worldwide. Also, you will be able to recognize how they are delivered and act at the cellular level. Also, appreciate pharmacokinetics, biodistribution, and radiological impact, like what exactly it is, how it is important. Exploring again the logistics and administration in the clinical settings, and to be able to understand how patient response is getting monitored throughout the therapy as well as the after therapy post treatment as well. Okay, so these are our learning objective where we are aiming uh, of that needs to be satisfied after the end of the session. Okay, so let's start. Every title is in a green, so that because you can see in every point we have subtypes. Like in the third point we have so much of things to discuss, starting from the pharmacokinetic to bioinformatics to radiology, right? So I have kept the color for you to understand the topic, which is the different topic exactly, and to differentiate the types and subtypes very easily. So that is the meaning of the green color. So remember throughout the session. So very first topic we have today, that is a key therapeutic agents in use today. So basically we have with us 177 Lu dotatate, very widely used it is. Now the mechanism behind it. It is very important for the NETs. Let's just remind ourselves, neuroendocrine tumor, because those tumor cells aggressively express one specific receptor, which is a somatostatin, SSTR2, right? And this particular radio pharmaceutic agent is responsible to bind with this SSTR2, okay, and then destroying the whole tumor cell, right? We'll see what is the mechanism exactly. Next, we have that is a, sorry, it is I think I-131, but one it is written by mistakenly. So it is I-131, that is iodine. Same agent used for diagnosis and same agent used for therapy, but in a high dose. Okay. And third is here with us, that is 177 LU-PSMA, prostate specific mammalian antigen, responsible for the prostate cancer, which is in a resistant form. Okay. Treatment approach. So we will now look at the three major this therapeutic radiopharmaceuticals used in the clinical theranostics today. And for each, we will discuss the cancer type in which they can be used, the target, like exact what are the receptor and what are the specific receptors which are target of it, diagnostic pairing, like how can you pair the diagnosis with this particular agent. If you are going to use 177 lu dotatate, what needs to be diagnosed, what is the radio tracer? So obviously 68 ga, right, the dotatate, that is a diagnostic pairing with this. We'll discuss this in detail, and also we'll see some real life clinical applications by the case studies. Okay, so that is our first topic to discuss. So let's start with the very first, that is the lutetium 177 dotatate. Okay, luthesera, very important, very, very important agent it is. So what it is basically? It is a radioactive therapeutic agent bound to a molecule that mimic like a somatostatin, which is a hormone. Okay, and the property which is making it, the it is making them as a mimic to the somatostatin hormone, that's make it the more targetful. So basically it is binding to the somatostatin receptors, specially called as SSTR2, which are overly expressed in NETs, neuroendocrine tumors. For example, some pancreas or a small bowel tumors, okay, NETs. So this is the importance of the very first radioactive agent, that is lutetium 177 dotatate, and which is useful in the treatment of neuroendocrine tumors. Let's understand further how it works. So basically, the compound binds to the particular somatostatin receptor on a tumor cell. It's internalized into the cell. That is our second topic to understand what is the exact mechanism behind this internalization, right? So it is just generally now understand on a brief level that it is getting it is internalized into the cell, and this Lu-177 emits further the very particular radiation, which is beta radiation. Now this is very harmful in a way, because beta radiation has some of the effects on nearby healthy tissues as well. Okay, so it is prominently like 90% effective in damaging DNA and causing the cell death of the tumor, but it is also responsible to cause damage surrounding healthy cells, the beta radiation. Okay, so it is very important agent to understand when it is going, like last lecture someone has questioned that what are the situation when you cannot go for it, right? So I explained that the patient who are having kidney impairment, they cannot go for it, right? Because if you are still want to use such radio active agents in the patient who is having renal impairment, so there are alternatives. Okay, some of the amino acids are being administered simultaneously to avoid this kind of effect from the beta radiation. We'll discuss detail in the next upcoming slides. Just understand briefly, because the first point is overview, so we are just briefing it about. So what is a pair diagnostic? We can guess it, right? So 68GA dotated PET CT confirms the presence of somatostatin receptors expression before the treatment initiation. When it is getting confirmed by this particular radio tracer, that is 68GA dotated, then you can go for the treatment of lutetium 177 dotated, right? So it is only SSTR positive, you can say. So now if you are having a report on your hand and it is showing this SSTR positive type of NAT, then you can directly suggest the treatment which is we are having lutetium 177, right? So only SSTR positive patients are qualified further for this particular therapy, which is the true example of precision and personalized medicine. We are going for first the diagnosis with the gallium 68 dotated and we are scanning it under the PET. Now you know what is the meaning of positron emission tomography. We had enough discussion in yesterday's lecture, right? So basically, we are scanning it with the radiation, and we received what? We received some of the illuminating, or some of the radiating part in the scan, and that is exactly where your tracer is being absorbed, and in what extent it is being absorbed, that is also has been seen in the report of PET. So that is qualifying your patient for the suitable treatment which is associated with LU 177. Okay, so that is exactly the meaning of this. What is a clinical example to understand this particular thing? So we have a 52-year-old male that is presented with the again a vague abdominal pain. CT, of course, was inconclusive. So they are moving forward with what? 68Ga rotated PET CT. And that revealed multiple small metastatic lymph nodes. As I earlier explained in yesterday's lecture, that your PET CT with this radio tracer can identify the smallest metastatic lymph. So obviously, it revealed multiple small metastatic lymph nodes in the abdomen, and the report shows SSTR positive. I assume that now you know the meaning of SSTR positive because we have been discussing since 2 days. Okay, so selective serotonin, SSTR is standing for again the somatostatin receptor, right? So somatostatin receptor positive suggests that the patient is having some of the metastatic activity at a site, and it is eligible to receive the cycle of this particular 177 LU-dotated, right? So basically, he received 4 cycle of the particular treatment over the 8 months. Now the question arises, why the 4 cycle over 8 months? Basically, how it is designed. So let me tell you, this 177 LU-dotated therapy for this NETs typically involves 4 cycle administered every 8 weekly, okay, 8 weeks later, and over a period of 8 months as well. Now this regimen is totally based on the clinical trials and is designed to target cancer cells expressing the SSTR2s, okay, while minimizing toxicity to the healthy cells. Basically, क्यों इतना time दिया जाता है? Why they are maintaining such intervals? The treatment is given into the cycles basically to allow for recovery period from the potential side effects that may be arising with this radiation effect. Okay, so another reason is to optimize the therapeutic window as well. So the 8 week intervals allow for the radioactive the agent to for example 177 LU to excretion from the body so that it can be excreted while still maintaining a sufficient concentration of a drug in the tumor portion. Okay, so that is exactly the meaning behind putting such a long interval in between cycles, because we don't want the side effect and we don't want the toxicity itself, because radiation has lots of side effect, and you have that question since very first lecture that what are the side effect. But it is in our fourth session, like we have a descriptive topic to discuss about the side effects, so do not worry, but just have a thought that it the cycle, the period is for 8 months. So basically the intervals are very important to optimize your therapeutic window, the therapeutic range of your radiopharmaceuticals into the body. Okay, so what is the result? You can see the result, it is increasing. It is greater than 50% of reduction has been seen in the tumor volume after the 8 months, and that shows some improved symptoms and stable decision on the follow-up imaging. So basically, the takeaway from this example is this is the classic case, right, of using targeted therapy to manage difficult to diagnose cancer effectively. But you can observe here, before starting with 177 LU dotated, we already had 68 GA dotated as a diagnosis. So we are more precise and more targeted with the therapy in this case, right? So that is the example of targeted therapy. Moving forward with the second agent, we have with the same isotope, that is lutetium 177 PSMA, that is for the PSMA variant is 617. So basically, shortly it is written as 177 LU PSMA, right? So basically, this is for prostate cancer in form of resistance. So let's see what it is. PSMA 617 is again a radioactive molecule that binds to what? As its name suggests, it is bind to PSMA, prostate specific membrane antigen, highly overexpressed in case of prostate cancer. especially in the advanced disease. You can see here for advanced prostate cancer like MCRPC, that is a metastatic form of castration resistant prostate cancer. In that particular case, this is the treatment approach to go with. Let's see how it works. So, how it works exactly? It is binding specifically to this prostate specific membrane and antigen, which is present on the prostate tumor cells, and this lutetium 177 that delivers targeted beta radiation. As I already explained, it is emitting the beta type of radiation. We have the type of radiation as well. Don't worry, we'll go by one, and that you can connect the dots that okay, that 177 LU is having a beta radiation, right? And again, minimal effect on the non-cancerous cells associated with the PSMA variant. And what is the pair diagnosis? So obviously, if you want to go with this treatment, you can first diagnose the patient with the radio tracer 68 GA PSMA PET CT that confirms the presence of prostate specific membrane antigen expression in the form of metastasis. And that imaging is also used to monitor response post therapy as well. Right. So once the patient is receiving this Lu-177 PSMA, after it also, like during treatment and sorry, for the post treatment, post therapy, the monitoring response is also associated with the same diagnosis, radio tracer, right? So again, we are having a clinical example to justify this. So a 60-year-old male, again with the resistance form of prostate cancer, had worsening their bone pain and rising PSA level. That is despite of the hormone therapy. I will explain you what is PSA, normal range, and how it is being monitored. So basically, this is the case where it was observed that the bone pain was very in worst case, and the PSA level was also rising despite of the hormone therapy was prescribed. So they are going forward with the 68 GA PSMA PET CT that is further revealing multiple PSMA positive bone lesions. Now this is a resistance kind of therapy, the case, because it is already there. The hormone therapy is already there. Still, the patient is having the complaints. So he was given again a 6 cycles of 177 LU PSMA therapy. Again, the justification is same for the 6 cycles. This number of cycle was determined based on the clinical trials were that demonstrating further the favorable safety and the efficacy profile for this, the treatment duration. So while some patients may show the high volume residual tumor burden after the 6 cycles as well, so we can extend in that case the therapy beyond this point, but it is for general, it is for the 6 cycles. You can also extend the therapy beyond the point, is often limited it is by the the some concern should be monitored and potential toxicity should be monitored if you want to again repeat the same therapy, but it is for the 6 cycles. Okay, so post treatment, again the pain score was reduced. Now what is pain score and how it is monitored? So that is general topic to discuss. Pain score basically, it is the intensity of pain which is getting which is we can say the check by using certain scales. So this could be on the scale of 0 to 10, where the 0 means no pain at all and the 10 means the worst pain you can imagine. So some hospital also use the pain scale such as 0 to 4 as well, like in whatever my hospital was using, that was about 0 to 4. So there are several different scales available, and examples are also there. For example, we have the Wong Baker's pain rating scales, right? So these are the example. We have also the most common one, I can give you the example, visual analog scale, VAS, that is also monitoring the pain score. Okay, also we have NRS, numerical rating scale. Okay, so these are some of the pain scale that was checked to check the intensity of the pain. So basically that was greater than 70%, and the PSA dropped from 210 to 12 nanogram per ml. Now imagine the starting point is 210. Now this PSA level, it is very very high. Okay, PSA level of PSA basically stands for the process specific antigen, right? And this PSA level of 210 ng per ml is very high. Significantly, it is increasing the suspicion of prostate cancer, nothing else. Okay, and what is the reason behind this significant drop? So the reduction of this 12 ng is again a positive, it is showing a positive development, but suggesting that treatment or other intervention have been effective in the lowering PSA. That is also the post treatment analysis is stating, but it is still in an elevated form. Okay, so a PSA of 12 is still considered elevated, please remember, and is above the typical normal range. Let me tell you the normal range. Generally, it is considered below 4 nanogram per ml, that is normal range of PSA. So 12 is still high, but drop from the 210, it is showing a positive outcome. Okay, so he resumed daily activities with significant improvement in a quality of life, and that is possible because of using 177 LUPSMA, right? So that is the ultimate case. What is the takeaway? So in late stage cancers like this in a resistance form, this therapy can actually relieve symptoms, reduce tumor burden, and improve the overall survival rate even when other treatments are failing. So because it is a resistance case, hormone therapy was there, right? But still the case is there. So in that particular complex case, your PSMA, LU-PSMA is very, very important. Next agent, the last one, radioactive overview that we have, that is iodine 131. So basically what it is, that is a classic example of radiopharmaceutical therapy where iodine 131 is taken up by what? By your NIS, that is the sodium iodide synthetase. Now what are they? So basically it is a protein-like structure that transports your iodine into the cells. Just simple as that. It is a protein like structure that is helping to transport iodine into the component which is the iodide actually into the cells, particularly in the thyroid gland, and is very crucial for thyroid hormone synthesis as well, NIS, right? And it also plays a role, important role in the other tissues as well, like the salivary glands and some mammary glands as well. Okay, so NIS functions is very vital for both diagnosis and treatment for the thyroid disease, and that's where exactly your radio of active agent is having to work to do, right? So in what cases it is important? So for differentiate your thyroid cancer, I already explained you the difference between papillary and follicular. Papillary is the most common form of the thyroid cancer, and follicular is 10 to 20%, right? So that is a difference, but it is actually used to differentiate what kind of thyroid cancer is patient having. Okay, so we again have how it works. So basically, after this thyroidectomy, that is a surgery, very common surgery, residual thyroid or cancerous cells still express the NIS, that is a sodium iodide synthetase, which is a sign of presence of certain tumor cells still inside the body. So basically, in that case, the switch here is oral iodine 131 is taken up, and that is emitting further the beta and gamma radiation. Now please focus on the two of the radiation. So basically in case of lutetium, there was only a beta radiation, right? In this case there is a beta and gamma radiation, further destroying the remaining thyroid tissues as well. And what is its use for? Obviously for ablation, post thyroidectomy, treating the residual or metastatic thyroid tissues, whatever residuals are left, and whole body I-131 scan, that is also provide diagnostic and the follow-up. So if you are using this for radio tracer as well in the diagnosis part, it can also give you the whole idea and the follow-up that how exactly your therapy is performing. Okay, so again, we have a clinical example to justify this. A 35-year-old woman is there, underwent a surgery basically for the papillary type of thyroid carcinoma. The whole body scan showed the thyroid remnants which were present inside the body, and she received a single dose of I-131 orally. Now, imagine it is a single dose. So, follow-up scan showed complete ablation because it was a, the residue of the cancerous cell that was around the system that was identified by the radio tracer, and the single dose can emit it. Okay, so you can see here she remains disease free on the follow up with the undetectable thyroglobulin. But I want you to focus on the age because it is playing a major role. There are always patient related factors, okay, that is affecting your treatment. So we cannot forget that. Okay, so there is a 35-year-old woman. So if the age was 53, reverse, the scenario maybe it will different, right? So we cannot forget age, we cannot forget lifestyle, we cannot forget here the environment which in which they are living. Basically every patient related factor has immense role in the cancer treatment. Okay, so what is the takeaway? So this RDIN 131 is one of the oldest and most successful example of radiotheranostics, showing long-term efficacy. Okay, so that is the overview of the first learning objective. There's all three of these therapies use the same strategy if you can observe, like find it, bind with it, and burn it with the radiation. Okay, so they are powerful tools because they go where the tumor exactly is, stay there for a long period of time, we know the cycle now, and release the radiation precisely over time, which is maximizing the efficacy and minimizing the damage at some extent, which was associated with the traditional and conventional chemotherapy, right? So this is the first learning objective. Let me see your if you have anything to ask. Process specific antigen, right? Mild to severe. Yes, Nanjo was for ADR. Also, the the scale is there that is being used for both of it simultaneously. What is the procedure for checking pain score? How to measure it? There are questionnaire. There is a questionnaire in the scale. On basis of that, you can identify. Just as if you know the example of MMSE, if you know mini mental state examination, that is using certain questions, and you can identify the status of mental health as well. So that is how exactly the same scale looks like. Removal. Okay, so there is no question for objective one. I think that's great. So we are moving forward with the second learning objective, and we are focusing on um, 6 cycles of LU-177 PSMA therapy for uh, how months? See, it is completely depend on at what stage it is. So that is the only reason why it is not mentioned in the case. Okay. So I think our next lecture, yeah, maybe the fourth lecture is totally dedicated to the cases. So we'll see the whole case behind this. Okay. So we'll discuss about the whole therapy. So do not worry, but it is completely depend on the stage itself. Okay. Kinetics we'll discuss in the second, third objective. Just wait for a few more minutes. Okay. Okay, so we can proceed with the second learning objectives. Okay, so that is talking about mechanism of action. So we'll see now what are the exact mechanism behind this radioactive agents. So let's see what is the objective. So objective is very clear to understand how this therapeutic radiopharmaceuticals locate your tumor cells, enter into them and destroy them. Okay, how exactly this is happening while sparing your normal tissues. So that is very important in case of radiopharmaceuticals. Let's understand it step by step mechanism. It is very first step is receptor targeting. Okay, so now you know 18F-FDG, fluorodeoxyglucose. Basically, that is mimicking like a glucose. So it will be binding toward, directly on the site of the cancer cell. So that is exactly the lock and key mechanism. Okay, so receptor targeting is the very first step. So every tumor type express unique flex. Now that is what exactly we are working on. If imagine, if sometime the genetic mutation, in future will come, and in such a way the tumor cell is getting mutated, that is happening in some kind of, rare cases, and you cannot locate exactly this thing, which is a receptor or any sign of unique sign which is getting expressed by the tumor. So that is exactly the key on which we are going, and exactly the key where our radiopharmaceuticals are going and binding, right? So every tumor type express a unique flex, which is known as the receptor on its surface. Say this, we have commonly neuroendocrine tumor with us. The target receptor is very clear. In that case of NET, we have direct somatostatin receptor, SSTR2. We have with us radiopharmaceutical to cure it, that is 177LU dotatate. For example, in the prostate cancer, we have target very clear, the prostate specific membrane antigen, the unique flag it is, okay? The unique design, the unique structure is being there on the tumor cancer cell. And we have that radiopharmaceutical for it, 177 LUPSMA. Thyroid cancer, we have NIS, sodium iodide symphoter, for which we have radiopharmaceutical iodine 131. Right? So basically, the very first step is the receptor targeting. You can focus on the mid part, which is a target receptor. So that is the exact mechanism. First, by injecting a particular radiopharmaceutical, it is the first thing that is a receptor target. Okay, so let me tell you sometime what happens. Some of the other organs which are having a high metabolic activity are also sensitive to catch this radiopharmaceuticals. Okay, because that is also expressing something, but in a less extent. We'll see in the next slide. So these radiopharmaceuticals are designed to recognize, ऐसे डिजाइन किया जाता है that it is recognizing and binding to only this specific receptors. Okay, but we cannot accurately say that it is 100%ly binding with the exact location and not with others. So basically, that is how the radiopharmaceutical has first target is to bind with the receptor. So analogy here, to think of the radiopharmaceutical as a lock and key system, same as a drug and receptor, our normal medication and receptor, right? So the tumor receptor is the lock and the drug is the key that only fits that the tumor cell on a tumor cell. You can see here the diagram which I have mentioned in the very first lecture. You can see here in a injecting form the eludotatate 177 is being administered into the body, and you can see the zoom picture where the cancer cell is expressing SSTR2, the somatostatin receptor, and you can see the yellow color is binding with the pink one. Pink is the receptor and the yellow whatever you have been injecting, right? So here is a dotatate LU177. Basically they are making a lock and key mechanism, and in very next part you can, if you are able to see, you can see the engulfment as well. Okay, so it is getting entered into the cell. That is a second mechanism. First is binding with the receptor. Okay, so target the receptor is a very first mechanism part. Secondly, it will be entering. Okay, and then the DNA damage occurs. Let's talk about it. So basically, there is a second step which is a binding and internalization. So basically, it is getting into it, entry into the cell. Okay. So once the agent binds to the receptor, whatever our agent, maybe it is a 177 LU-dotatate, let's have example of it, and it is binding with the somatostatin receptor. Okay, what happens next? The cell engulfs the whole compound, which is endocytosis, naturally happening, right? Because they are mimicking like a somato, the hormone itself, and which is mandatory. Or if you are using 18F-FDG, it is mimicking like a glucose, which is also mandatory for cancer cell to grow. So that is the only reason the engulfment takes place. But let me tell you, some of the mutations are also have been seen. In that case, they are also mutated in certain cases. In which case, in that particular case, they know the difference now. Okay, so the cell maybe they know the difference and they are not getting bind. So basically, that is another part we'll discuss in the future aspect, the last lecture of our whole session. But here we are discussing a general part that the cell engulfment is a second process, and it is the endocytosis, and then the radioactive isotope is now inside the tumor cell. Okay, so this is very crucial part, second one, binding and getting entry into it. Why? Because it localizes the radiation directly inside the cancer cell. Okay, minimizing the exposure to healthy cells. So if your binding and entry is not appropriate, you can imagine the radiation effect will be on the healthy cells as well in that particular scenario, right? That is the importance of the second step, which is binding. Okay, you can see here in a very zoom picture, I have a schematic presentation mentioned here so that it will be very easy to understand. See here the 177 LU-dotatate being bind with the somatostatin antigen and getting entry into it, right? So engulfment I have already mentioned in the last slide, and this is the entry. Okay, and then the step by step the degradation happens. In some case it is happen, in some case it won't get any effect. So that is the case. And the third and the last effect after the endocytosis, that is the radiation release. For example, in case of lutetium 177, beta particles will be there. Okay, and in iodine there is beta plus gamma radiations are there. So the ultimate thing, radio pharmaceutical, it is they are having this frequency to release, right? To decode their DNA, or we can say just the same simple analogy. You can imagine that the same radiation is responsible for cutting down your double-stranded tumor cell DNA. Right now, there will be no DNA, there will be no cell. So basically, that is the exact mechanism is behind this radioisotopes. So these radioisotopes, whether it is lutetium 177 or iodine 131, it is further emitting the beta particles on inside the tumor cell. Okay, beta particles are in very high energy electrons, and it is in a very high energy itself, and they can travel up to 0.2 to 2 mm. Okay, and that is only for your understanding, that that is nothing to go with remembering those frequency, but this is only for your reference, that the range is being written here. And this range is very enough to damage the tumor cell and the few neighbor cells as well. As I earlier said, that this radiopharmaceutical has effect on the tumor cells as well as on the healthy cells, right? So binding and entry is very important, and this is a very important part of radiation as well. So this is known as crossfire effect. If I can explain you the definition of it, so the crossfire effect in the radiation therapy refers to the ultimate phenomena, it is where the radiation emitted from a targeted radioactive substance, like this we have the example, damages not only the cells it directly interact with, which is the cancerous cell, but also with the adjacent cells, which is the nearby cell. Okay, and that may not be directly targeted. So basically that is the crossfire effect. Simply, your radioisotopes are triggering your healthy cells as well, which is the neighbor cells. So that is a cross effect that may be observed with the range of zero point 0.2 to 2 mm of the radiation which is getting emitted from the lutetium 177, right? So if the tumor is very small or scattered in the form, that is a micrometastasis, the term which is being used for the small and scattered tumor is the micrometastasis. This is very ideal in case. Okay, because it is damaging the neighbor cell as well. So it is in a scattered form. It may, we can emit this. So basically, that is the phenomena for the third step. So the point to emphasize here is this short range, that is a 0.2 to 2 mm, is why it's considered internal and highly targeted therapy. Okay, unlike the external beam radiation. So external beam radiation is another type of the radiation which can be used in certain, in certain rare and big cases, we can say. But in case of this small tumor and scattered, this is the ultimate thing because they have a narrow and a short range, okay, to emit the radiation. So these are the three step, and the fourth is the last one, but these three are the main. So in many of the reference book you will find this three step only. Okay, so very first is the receptor binding, second is to sorry receptor target, and second is the binding and getting entry into it, and the third is the radiation release. But the fourth here, I think, for moving forward with the fourth one, before it you can just simply analyze this schematic presentation to understand the whole process very easily. Okay, so here you can observe some of the agents which allude that it is coming, binding with the blue color receptor, getting entry into it, and some radiation is happening. And you can simply understand the nucleus if it is visible. It is really visible actually. Radiation is targeting the DNA. Okay, so that is our fourth step. This is anti-tumor cell basically. Okay, so that is SSTR2 is written here, somatostatin receptor, right? Fourth and the last step is the DNA damage and apoptosis. Apoptosis, program cell death. Okay, so basically DNA damage is because of radiation. So once these beta particles are emitted, they cause what? As I earlier explained you, double strand DNA breaks directly of the tumor cell. Okay, and if there is no DNA, there is no the cell survive, right? So they also generate some reactive oxygen species on another hand, but it is only a 10 to 20% of mechanism. Okay, so it is amplifying further the cellular damage. But the 90%, 80-90% effect is breaking the double strand DNA. Okay. In many competitive exams, I found this question. Okay. So basically, they ask that what is the exact reason behind uh, causing the tumor cell death by the radio pharmaceutical agent. So it is not radiation like radiation effect itself, it is to break down double strand of DNA. Okay, so this is very important. The fourth part, which is not written in the reference book, but in many reference book, but it is there. Okay, it is a fourth part of the mechanism. So what is the result? The tumor cell detects it, cannot repair the damage itself, and it triggers the apoptosis, that is programmed cell death. Sometime it may go with the necrosis as well. I think it is there. Yes, some tumor cells may also become, sentient and undergo necrosis as well. But many is going with the apoptosis, programmed cell death. So that is the ultimate mechanism of our whole, the radio pharmaceuticals. You can see here the exact mechanism again with the help of schematic presentation. See, here is a 68GA rotated PET scan. The now I hope you are eligible, you are able to understand what is 68GA rotated PET. Basically, it is a radio tracer. Okay, it is tracing exact location, and you can see the color image as well. And patient is receiving GA68 in the bottle. Okay, that is also being seen here. So basically, on the right side, we have a treatment which is 177LU, okay, associated with a specific diagnosis. So what is happening here? You can see completely the binding of the receptor and your radiopharmaceutical. It is getting entry into it by engulfment, attacking the nucleus, attacking the DNA, and you can see the last image, the pink one, and that is fragmented DNA is being seen. So radiation damage the DNA causing cancer cell death, you can see here. Okay, so this is the exact mechanism of radio pharmaceuticals agents which we are using it. Okay, so I think it is very clear and understandable now. So I would like to request you all to see this video, how exactly this mechanism is happening. This is a 3D dimension video to show the exact procedure, how it is being administered, and how exactly it is playing their role. So it is only a 4-5 minutes of video. Please pay attention to it.
My name is Dr. Eric Liu, and I'm a surgeon here at the Rocky Mountain Cancer Centers here in Denver, Colorado, where we specialize in caring for patients with neuroendocrine tumors and neuroendocrine cancer. We offer a therapy called Lutathera. It's also known as peptide receptor radionuclide therapy, or PRRT. It's quite a mouthful. But basically, it's an injectable radiation therapy. You may have heard of radiation therapy for other kinds of cancer, like breast cancer or esophageal cancer or brain cancer. That's different because you can shine the radiation from a machine into your tissue. Well, Lutathera and PRRT are a little bit different. What we do is we actually inject radiation into your bloodstream, and then we use a special targeting method that carries the radiation directly to the tumors, and the tumors eat the radiation. And once it's absorbed by the tumors, then the radiation is just inside there and it treats the tumors specifically. So instead of getting a lot of that toxicity and trauma to your skin and other things that can happen from external beam radiation therapy, this one targets your tumors directly and can treat them for many, many weeks. And we found it to be extremely successful, and we want to offer it to all of our neuroendocrine patients. Because of the success of our Lutathera program, Rocky Mountain Cancer Center has actually built a brand new nuclear oncology suite. It's a specially designed suite that provides patients who are receiving the special Lutathera treatment in a space that's designed to protect the staff and to increase the number of patients who can get therapy. Before, maybe we could have 1 or 2 patients a week, but with our new center, we can actually treat many more patients a day. And we're very excited about that because Lutathera was actually just the tip of the iceberg. There are new treatments in nuclear oncology coming out for other kinds of cancer, including breast cancer and maybe prostate cancer, and who knows what else is down the pipe. So we're very excited, and Rocky Mountain Cancer Centers is staying right on the cutting edge by building these new facilities and investing in new ways to take care of you. Call my team today for an appointment.
Okay, so that was all about the showing the how exactly this Lutathera is being administered. So before proceeding with the third learning objective, I would like to see your questions if there are any. Will they work for malignant tumors? For like what? Radiopharmaceuticals. Yes, for malignant tumors as well, it is showing their impact. We'll see, we'll discuss about the cases in the next upcoming lecture. So, it will be very clear to you that how exactly, in what conditions it can be used and in what condition it cannot be. Okay. Next question. Okay, so next question is, it is preferable in case if the patient is comorbid with any autoimmune. That's what I am talking about, that we will be having cases in upcoming session, and only case we'll discuss about it. Okay, so I think you have seen the brochure. If you have seen the brochure, in the fourth session we can included the cases itself, with the comorbid, without comorbid, everything. Okay, is it given IV flush or IV? Okay, radiopharmaceuticals are typically given IV, and while some are given slow infusions, other are injected rapidly, followed by the saline flush as well. Okay, so both. Are this following one compartment or two compartment kinetic? Kinetic part is about to discuss, so we'll discuss in detail. So do not worry. As I earlier said, IV slow infusion, it is not associated with one single thing. Some are given as a slow infusion, others are injected rapidly, followed by the saline flush as well. Okay. Yes, we'll discuss about the examples as well in detail. Okay. For now, I really want you to understand the pharmacokinetic aspect, which is our third learning objective. How the isotope handling are done during the therapy and diagnostic. That is exactly the video has been showing that it is the criteria where in this today's topic I think we have that logistic, right, clinical logistic, that is talking about handling it. So just wait for a while, it is coming. Okay, let's move forward with the third learning objective for today, and that is pharmacokinetics. So, let me tell you that for medication, pharmacokinetic part is very, very crucial. But for the radiopharmaceutical, apart from the radio pharmacokinetic, we also want to understand biodistribution and radiobiology as well. Okay, so that is a very important part in case of radiopharmaceuticals. So we need to understand the kinetic part, distribution part, and the radiobiology. Okay, so we'll start very first, that is a pharmacokinetics, first portion to discuss. And this PK describe, as we all know the definition, what the body does to the drug. Okay, and what exactly the body does to the radiopharmaceutical, that's we need to understand from the time it's being administered to when it is getting excreted from the body, we need to understand in detail. Okay, so this is the flow like a radioactive isotope, and we have a linker and we have a targeting molecule, which is the exact linker is the one which is responsible to take your radioactive isotope to exactly bound on the target site. And also we have target protein, which is being reflected, whether it is receptor or anything else, on the cancer cell, and itself a cancer cell. So that is the ultimate flow from which you can identify exactly your radioactive isotope is being transferred from one to other things. Okay, and that is what nothing but the pharmacokinetics. Let's understand in detail about the first lutetium 177. So the ultimately 177 Lu, that is the radiopharmaceutical, and the half life which is associated is 6.7 days. In the yesterday's lecture I have elaborated the concept of half life, the half portion of particular radiopharmaceutical which is being excreted from the body, that is the half life. Okay, it is just exactly same as the medication and whatever the other drugs we are using in the healthcare. So basically, it is a 6.7 days that allows your extended tumor exposure while still manageable for the logistic and safety. Now, what is logistic and safety concerns? So now have the cycles in the 177 LU, right? We know that it is being in a cycle, and it is making some interval is very crucial. So basically, that is exactly how the half life of the particular chemical moiety is designed. Okay, what is its clearance? So clearance is primary renal, Now this is very important to understand and also to remember. So whenever you have prescription that suggests some lutetium 177, you need to check some of the kidney, the test. So basically the renal function test. So the clearance is associated with primarily with the renal, the kidneys. So tumor retention is another factor to understand here. So once bound to the receptor, whether it is process specific membrane antigen or whether it is somatostatin, right, it remains inside the tumor cells for the long enough time to deliver your therapeutic radiation dose. That is what exactly the tumor retention meaning. Okay, many of time your the file of the cancer patient has this name, the name which is written tumor retention, and many of maybe not having idea what is the meaning of the retention. So basically, your radio pharmaceutical has a long enough time to get inside the cell and staying there and doing the therapeutic radiation in a very precise manner. So basically, that is the lutetium 177. You know the half life. You know the clearance. Okay. So the clinical implication is the moderate half life ensures repeatable dosing, like every 6 to 8 weeks later, like according to the type, according to the stage, according to physiological finding of the patient. Okay, so there are multiple factors affecting this 6 to 8 weeks period, and this is completely depend on the physician and the clinicians who are the oncologist, they are prescribing something like that. So basically that is the half life which ensuring further the repeatable dosing after every 6 to 8 weeks with the manageable radiation protection needs. Now what is this manageable radiation protection needs? Okay, so we know that lutetium 177, we know the kinetic that it is going to be cleared out by the renal route. So basically we need to be very precise with it. So यहाँ पे हमें क्या करना पड़ेगा? We need to administer something which can protect your kidneys when the radiation or the radio isotopes or radiopharmaceutical agents are getting inside the kidney for the clearance. So we need to have something with us to protect our renal health in these cases. So what are the parameters? We'll discuss one by one, like after completing this iodine also. So we have to be very clear with the monitoring as well as protective strategies. Okay, that is our next topic to understand. So let's try to understand here the iodine 131 pk, what it suggests. Half life is 8 days. Actively, it is taken up by the NIS, the sodium iodide importer, which is the abundant in the thyroid tissue, which is, and it is retained even in the thyroid cancer as well, and eliminated via urine, again the same route, with a high radiation safety concern. So patients are often kept in isolation post dose. So remember, whenever the patient is receiving iodine 131, the patient should be kept in the isolation post dose for the longer period of time as compared to the Lu-177 dotatate. Okay, because if you remember, iodine has two of the rays, beta and gamma. Okay, both. So the clinical implication is due to this rapid uptake and the excretion, hydration and bladder emptying. These are the very crucial point to minimize this radiation effect to the bladder because it is eliminated via the urine route and reduce the whole body radiation dose as well. So in case of this, the patient receiving iodine 131, make sure patient is getting enough hydration, and bladder emptying is very very crucial to minimize the side effect and adverse drug reactions. We'll discuss about this side effects in upcoming lectures. And it will be surprising that to see that how dangerous side effect we are having with the radiopharmaceuticals, but it can be avoided with certain clinical implications in the practice. Okay, so that is the whole thing. And now moving forward with the bar distribution part. So what it is, like bar distribution is about where your radio pharmaceutical travels in the body. Okay, so where it is heading is bar distribution, and it is completely depends heavily on your target receptor expression. Okay, because that's exactly where your radio pharmaceutical is traveling, also your physiological excretion. Okay, so that is the whole route, like from the entry to excretion. The bar distribution is the phenomena that is going to be discussed whenever it is a radiopharmaceutical travel story. Okay, so key principle in the bar distribution is the radio pharmaceutical goes where the target is, exactly where the target is, and but may also go where the receptors are expressed in the normal tissue, as I earlier said, right? Whatever uh, target specific radiopharmaceuticals are available in the market, but it is going to be there where the expressed, which are normally expressed some healthy tissues as well. So it will go there also, and there will be some side effects. Okay, so biodistribution suggests us to see on that aspect too. For example, in the 177LU dotatate, where it is binding with the somatostatin receptor expression, the high uptake, कौन करेगा, who will be having a high uptake of this particular radioisotope? Obviously NET tumors, because they are having a high expression of SSTR2s, right? So, and pituitary, spleen as well. You can see here moderate uptake also can be happen with liver and kidney. So your liver and kidney are also going to have a moderate uptake of this particular radioisotope or radiopharmaceuticals. Okay, 177LU dotated. So in that case, what you need to do, I think I already explained you that something should be in the co-infusion to protect. If you know the clearance is associated with the kidney root, and also it is going to affect the liver and kidney, okay, liver and other organs as well, like a pituitary, spleen as well. So there needs to be some co-infusion with the therapy. So basically that is a another very important aspect of the radiopharmaceutical use. So the co-infusion, the term itself has meaning. It is infused with the therapy. Okay, so the co-infusion of amino acids that further protects kidneys from radiating damage. How? Now the question is how, like how amino acid can protect kidney from radiating damage. So basically amino acid, specifically positively charged. Okay, positively charged it is. And for example, we can have example like L-arginine, L-lysine. Okay, these are some amino acids which are positively charged, and that can protect the kidney from radiating this damage by the exact mechanism which is known as competitively inhibiting. So they make the competition with it, and they are speedy, so they will be competitively inhibiting the reabsorption of these radio tracers in the proximal tubular cell, PCT cells in the kidney. And this mechanism reduce further the radiation dose which is being absorbed by the kidney during the treatments like this, the PRRT, which is the Lutathera basically. So the co-infusion of amino acid like L-arginine, L-lysine, right? These are positively charged, and this is competitively inhibiting the reabsorption of radiation in the particularly PCT part of your kidney. Okay, nephron. So that is exactly the mechanism which is simultaneously being placed to protect your other organs, which is very important. In case of 177LU PSMA, where the prostate specific membrane antigens are there, high uptake, obviously prostate cancer lesions, but also it can taken up when it comes to the bio, it when it comes to the for PK and the whole mechanism when you are studying it. So basically it is also taken up by the salivary glands, kidneys, and some lacrimal glands as well. So these are PSMA positive normal tissues. See the name. You will be finding this name in the cancer case many times. Okay, PSMA positive normal tissue, meaning this might be the confusing. Like it is PSMA positive, like they have the process specific membrane antigen suggesting a metabolic activity, but the tissue is on a normal stage. So that is how exactly it is being seen. So plus they may cause some of the the symptoms like xerostomia, that is the dry mouth, due to salivary gland irradiation. So basically if the irritation is happening with the salivary gland, the consequences like dry mouth is very associated with this. Okay, so this is exactly how the other organs are being affected by the whole process of radiopharmaceuticals. So also we have the iodine 131. Let's understand that too. So strongly it is absorbed by what? Thyroid tissues, obviously, including a cancerous remnants as well. But it can also affect some of the salivary glands, and it is leading to inflammation. Okay, CLR dentitis. So basically that is associated with the inflammation. Okay, so this is also affecting other organs. So I think in yesterday's lecture someone has question, that it is having effect or not, where I already explained you that in upcoming lectures we have in detail. Okay, so that is exactly what the pharmacokinetic and all of this is have the link of where exactly it is leading, and what other organs may be having effect of the some popular radiopharmaceuticals like this. So in this case, what is needed? The dose calculation is very critical, right? Based on what is tumor burden. What do you mean by tumor burden is stage, type, okay, the physiology of patient, risk factors, comorbidities, everything is under the tumor burden. So based on tumor burden, the uptake which is seen in the PET, like exact extent, like how intense it is being seen in the PET CT, the organ function, especially the renal one, because everything is excreted from that particular route, we need to check that also, and some radiation safety guidelines that needs to be monitored when you are deciding for such therapy. Okay, so that is very important. Let's understand radiobiology, the third point. So this section explains how this emitted radiation affects tissues at a very cellular level, how it is emitting radiation, right? So we have a types of radiation. Both this lutetium 177 and iodine 131 are the beta emitters, you know now, and which means they release high energy electrons that travels the short distance. Okay, we know the range now. So basically this is the summary table to just the brief you about. This is the something not we need to mug up, or uh, this is not something to remember for a long time, but you just need to know that there are two types of isotopes, right? 177 Lu and the 131I, whether it is for PSMA or whether it is for dotatate, right? Lu. So we have a type 177 Lu is associated with the beta emitters, and the iodine is beta plus gamma, and the range is also written here like zero point 0.5 to 2 mm, and for the iodine it is 0.5 mm plus the long range gamma is there, and that exactly reason behind putting the patient in the isolate form after post the post therapy or after therapy. Okay, so because it is having a gamma rays, that is a long range. Okay, so the key use here you can see the beta rays are used for precise tumor killing, and the beta plus gamma, so the gamma is particularly for the dual diagnostic as well, like it is for monitoring post therapy and some therapeutic use as well. So that is a radiobiology. Okay, this is how the radiobiology is being explained, that what kind of radiation it is having, what is the range of that particular radiation, and how it is exactly damaging the tissue at the very cellular level. Okay, basically it is damaging the DNA double strand. So mechanism of action, let's see. As I earlier said, it is direct damage the DNA, the double strand, it's break. Second mechanism for radiation is a indirect damage via some oxygen species, that is a reactive oxygen species. The radiation reacts with the water in the cells. ROS कैसे बनता है? So basically radiations are reacting with water. Cell is having water, right? So water in the cells to produce something which is very dangerous, that is ROS, reactive oxygen species, which also damage further the DNA and cellular proteins, emphasizing further the process of killing. Okay, and the third process is direct, we can go for the programmed cell death, apoptosis, or mitotic death. Okay, so tumor cells are enabled to repair the die during the divisions, and or you can say entering into the programmed cell death. These are the mechanism at a very cellular level it is happening because of radiation effect. Okay, so that is a radiobiology. So there are some of the crossfire effect as well, which is known as the bystander and the crossfire. As I earlier said, that it is also going to be having effect on the healthy cells, right? So the short range of beta particles associated with Lu-177 dotatate or PSMA that ensures high local damage, obviously with the minimal harm to surrounding healthy tissues, but it will be there. Okay, so, but in a small tumors or micrometastasis, you can say like a scattered form of the tumor, crossfire effect helps again to kill the neighboring cancer cells, even if not all have bound tracer. So in that case, healthy cells are also getting dying, but it is a positive sign, right? Because in scattered form of tumor or a small tumor, right, we need a crossfire. Okay, so that is the two aspects, two different aspects to understand here. I hope it is clear and making sense. So, what is the recap of this particular whole? understanding of this pharmacokinetic and biodistribution and radiobiology. So, with the help of pharmacokinetic, you will be ensuring that we are delivering the drug efficiently. With the biodistribution, it is ensuring it goes where it's needed, where the exact target is, and the radiobiology makes sure it kills with very precision. Okay, so sparing the healthy cells. So together they form the foundation of how radiopharmaceuticals succeed in treating cancer with high selectivity and minimal toxicity. This is a very nice, it seems very nice to write, very nice to listen. But in practical aspect, the scenario is something different. Okay, so I will show you in cases in the next coming lectures that this is very good, that it seems very good theoretically. But when it is coming, practical case, it is not as smooth as it seems, like going, binding with the receptor, entering into the cell, killing it is not as easy. Okay, so but let me just give you the positive view today, that is the pharmacokinetic, biodistribution and radiobiology is helping us. Okay, and that is exactly the foundation of radiopharmaceuticals. It is combined formula. Okay. Okay, let me see your question before proceeding with the fourth objective. Just a minute. How the isotopes handling are done during, okay, handling clear. How many times can radiopharmaceuticals be injected? If adverse reactions occur during treatment, can it be spotted? What alternative treatments are preferred? Yes, these are very good questions actually. So basically, how many times, first question is how many times it can be injected. So it is simply firstly, if the the first cycle is there, it is only the one time. If you want to repeat, you need to check some of the clinical aspect and some of the ADR monitoring as well, which are associated with it. It is not for reuse. So if adverse reaction occur during the treatment, so during treatment maybe the hypersensitivity may occur, and some of the side effect we're going to discuss in the upcoming lectures that may arise during the treatment as well. And we'll discuss about how it can be spotted, and how you can check that whether the ADR is happening with the therapy or not. That is also we're going to discuss about it. Okay. And alternative treatments also we have, see, this is a novel perspective. Okay, this is very new in the treatment chart. So conventionally or the traditionally we have the chemotherapy, and that is the only treatment left if this is not working. What if the patient is suffering from renal impairment? That's what I am talking about. If the patient is suffering from severe renal impairment, this is contraindicated. Okay, severe it is contraindicated. If it can dehydrate the whole system when it is eliminated from the bladder, does it damage it? If it can dehydrate the whole system when it is eliminated from the bladder, doesn't it damage it? Yes, the damage is there, but it is a cancer, right? So we are checking the risk versus benefit ratio. Radio pharmaceuticals are harmful. The side effects are on a very large scale, but obviously we are checking for the risk versus benefit ratio and moving forward with it. And it is not dehydrating the whole system. Okay, what is the max safe concentration of any, we'll see the dose calculation is another part to discuss. Which type of patients are typically considered unsuitable for this therapy? I think in previous lecture we discussed about it. If the patient is in a pregnant state, if the patient is pregnant, or lactating mother is there, or lactation period is there, or some kind of renal impairment, or patient is sensitive, hypersensitivity chances are there, or any kind of other infection, comorbid conditions are there, so it is not suitable for it. What clinical factors affecting it will discuss in the upcoming sessions. Give that both thyroid hormones and iodine are taken up by the thyroid cells. Hmm? Given that both thyroid hormones and iodine 131 are taken up by thyroid, do they interact with each other's mechanism, or they acted independently? In some extent, they interact. You know, are you said 131 is taken orally, where and how it is being metabolized? See, with the case of oral iodine 131, the exact mechanism is pharmacokinetic is very different. So I have not included that because it is very basic when where exactly the oral tablet it is, right? But if you want, in case like the next case we have for the discussion, we will be more focused towards it. Okay, like oral tablets I have included in the case studies treatment chart. Okay, so we'll discuss it. In isolation, since long range gamma radiation effect is seen, will it have penetrative effect in the skin of the patient? No, that is, that there is very less chance of this particular situation. But and some of the techniques are also there to protect the the workers by this particular situation. So it is in upcoming. So upcoming slides में ये चीज़ मैंने बताया है that what are the logistics that can be adapted by the healthcare professionals and other persons also. So I will tell you what it is. Okay, so we can move forward with the route of administration part. So we have route of administration and clinical logistics as a fourth number of learning objective. And the most common route for delivering the radiopharmaceutical, now it is clear, it is IV injection intravenous. Okay. So that is the route of administration. Now the question is why only IV? So basically it is ensuring a systemic distribution so the agent can reach to the tumor cells throughout the body. Ultimate purpose is being served here, and the fast and controlled delivery is possible with the intravenous. Okay, so that is the exact reason behind IV is chosen for radiopharmaceuticals delivery. What is the procedure? So it is, I think in the clear video you have already seen that the administration administered via the slow IV push or infusion over a several minutes. As I earlier said, that it can be many in many patient I have seen also that it is with the fast, but it is very rare. Okay, with the other fusion solutions. So basically generally it is administered via the slow IV push or the infusion over several minutes, typically done in the nuclear medicine or the radiotherapy department under the supervision only. Okay, so it is understandable. What are the special consideration? So renal protection is being, it should be there with the 177 lutated, okay, lu rotated and PSMA. So if you are using 177 lu based therapies like 177 lu dotatate or 177 lu PSMA, these are partially excreted via kidneys. So what are special consideration? There is a high risk of renal radiation exposure. So especially if the tumor burden is high or if the uptake is kidneys, occur. So basically that needs to be considered, and special considerations should be there like co-infusion of amino acids. So the solution, what is the solution of it? Consideration में क्या करना है? You should be go with co-infusion of amino acid, which is infused 30 minutes before and during 177 LU administration based on the situation of patient. Okay, which is competing. It is, I think I already explained you the mechanism. It is competitively inhibiting, okay, the binding of radiopharmaceuticals in the PCT. So basically it is competes with the radiopharmaceuticals for the renal tubular reabsorption, further reducing the kidney dose. Okay, so the typically it contains, as I earlier said, L-arginine and L-lysine, or a commercial renal protection solutions are also available. Okay, but the solution has this kind of amino acids. So these are some special consideration needs to be in mind when the route of administration is being performed. So what is delivering radiopharmaceutical therapy? Let's understand that delivering this particular therapy isn't just about the drug, but it involves a full ecosystem of coordination. Okay, and that is nothing but a clinical logistics. Okay, very first we need to understand it is associated with radiation safety protocols. As I earlier said, a patient itself is an dosimeters, and the health workers and other people surrounded by it also use this particular device. So basically patients are radioactive after treatment as well, especially with the iodine 131. So depending on the isotope, 177 lu if you are using, it is lower external radiation only associated with the beta. Okay, and that may be managed as daycare and a short stay, while on the other hand there is 131 that emits the gamma rays. in combination with the beta. So that needs what? Isolation in the shielded rooms. Okay, and is required post dose. So staff also wear some dosimeters. Now dosimeter is device that make sure, the amount of ionizing radiation exposure. Typically it is worn by individuals. It is, they put on actually this particular device working with or near radiation sources, whoever is working with or near radiation sources, and it is used to monitor and record radiation dose, ensuring that individuals don't exceed safe exposure limits and helping to prevent further potential health risk also. So these dosimeters are crucial for radiation safety in the various settings, including some of the medical facilities, some nuclear power plants, and some research labs also. Okay, so this is a very important device actually. And a waste disposal is also follows a strict regulatory guidelines. This is a clinical logistic part one, radiation safety protocols. Understandabilities. Secondary, we need to understand is a multidisciplinary team. So this nuclear medicine physician, which will be, the responsible for overseeing this therapy and imaging. Also, we have radio pharmacist and radio chemist, those who prepares or reconstitutes the radiopharmaceuticals. So they are having a huge role here, right? We have nuclear technologists, like they are handling imaging and injection setup, and we have nurses to monitor vitals, hydration, and patient care during the infusion. So we need a multidisciplinary team to go with the radiopharmaceuticals. Okay. Also, we need a drug form like a the cold kits and ready to use kits. Both are different. So, what is cold kits? It's our non radioactive drug kit that is labeled on the side with the radioisotope, and more flexibilities for the centers with radiopharmacy access so that it can be refilled. And ready to use formulation, like it is pre prepared, radio labeled, and with a fixed shelf life. But it is convenient technique, ready to use, but it requires timely transport and use. So that is a complete clinical logistic that needs to be done if you are handling a radiopharmaceutical. It is a miscellaneous part, but needs to, discussion is important. But here is a note: all preparation must happen in lead shielded isolators with a very strict aseptic and radiological safety standards. You know how why it is so important, right? Because it is a radiopharmaceutical, it is having a radiation effect, and it should be in a safety standard, it should be in a very isolate form. So those are the miscellaneous topics to discuss, where we have an example of Indian hospital workflow. And we have Tata Memorial Hospital, TMH, Mumbai, one of the India's very leading cancer center it is. And what they practice is, see, 177 LU PSMA therapy protocol they have. So patient with this, resistant form of prostate, and they are confirmed with PSMA positive on PET CT, receive 6 week interval outpatient therapy. Each cycle is being monitored here, like the renal protection is given, whatever the the acids is being prescribed here, like L-lysine, arginine, 30-60 minute before. 177 LU PSMA injected over 15 to 30 minutes, and patients monitored for 2 to 3 hours post infusion as well. So this is a protocol they are having exactly using a 177 LU PSMA. Okay. So that needs to be in every cancer center. Some standard protocol should be there with predefined time that what exactly it needs. Okay. So what should be monitor, like blood test for PSA, very important. As I earlier said, the normal range. Renal function, because now you know the PK mechanism, like it is getting excreted from the renal route, so it needs to be checked. Follow up for PSMA PET CT every 2 to 3 cycle we need to check. What are the benefits? No prolonged hospitalization is needed. It is a cost effective technique, and we'll discuss about cost, don't worry. So okay, we'll discuss about cost, how it is effective and how it is not, and also efficient throughput for the high patient volumes. So, what are the key takeaway from this? The brilliance of theranostics isn't just in the science, it's in the delivery. Okay, from a precise IV dose to a safe and structured hospital setup, which is a logistic, the entire process is a perfect balance of biology, technology, and logistic. That is the conclusion of our fourth learning objective. Now, fifth is very simple and very short. So, let me just complete it and then we'll move forward with the question answer. And fifth is a monitoring therapy and follow up. Okay, so what needs to be monitored? Now you already know. Okay, so how is response evaluated further? You need to check again a PET CT scan with the same tracer, whether it is 68GA dotated or after being administered the 177 LU dotated. You need to check blood test for the PSA level for prostate, thyroglobulin for thyroid, right? And you need to also monitor symptom resolution like the pain, appetite, fatigue, which are associated with the cancer. So this is how the monitoring should look like. And also you can go for some non-functional imaging test as well. So we have the WHO RECIST criteria, and we have a PER CIST criteria as well. These are the topics for the discussion in upcoming lectures, so I have not elaborated in this slide, but this is very important when we understand further the cases in detail. So in that particular thing I will discuss about this, what is this WHO racist and PER CIST. So that we'll discuss in detail, but these are some of the monitoring things. Okay, what are the key takes away? So recap point here is theranostic agents are very precise, effective, and very personalized. A real-time pairing of diagnostic is there with the therapy, completely the foundation of theranostics. And we have this three, these are the key tools for today. Okay, now this is a small exercise for you guys. You need to read about two topics for today. Vision trial, I want you to read 177 LU PSMA, which is, simply just go on a Google and type this, it will be there. Also, you need to read NETTER, one trial, which is also trial associated with 177 LU rotated, to specifically understand, these two things. If you are reading, you will understand the whole scenario in detail. So this is a small activity for you guys for today. Okay. Okay, what are points to take home to understand? So we already understand the mechanism of action, what is the therapeutic radiopharmaceuticals are having, also recognizing how they are delivered and act at the cellular level, appreciating the pharmacokinetic, biodistribution, and radiobiological impact, explore the logistic and administration in the clinical settings, and to be able to understand how patient response is getting monitored. So this is the learning objectives only, and these are the points to take home. Okay. Okay. Given that okay, is in isolation, any chance of drug decomposition before reaching it to the target site? Yes, chances are there, but it is it is tagged actually. So the isotope is being tagged, so the chances as compared to our other medication is less. Okay. In case of oral, it is showing a harmful oral effects if there are any alternative route like IV. Yes, we'll discuss about side effects in detail upcoming lectures. Decomposition of this is a decomposition of radiopharmaceutical is a tough task, and assessment required high technology scientific techniques owing to issues with sandling or radioactivity. It doesn't usually decompose rapidly but converts to a metabolite. Yes, exactly. Decomposition is very important part. I think in last lecture we have that objective also. Are there any specific patient condition or contraindications where IV delivery of pharmaceutical is not recommended? See, there are certain cases in which this is not recommended, but this is a very last aspect, right? पहले ही check किया जाता है if the patient is having any renal impairment or any hypersensitivity or any comorbid condition, it is not suitable for radiopharmaceuticals. So that is the ultimate way to identify, but these are very least. Okay, I think attendance form everyone is asking for. In which part of India there is a wider use of theranostics? As I, putting the examples of different hospitals in every lecture, I'm trying to do it because many of the cancer centers are using it. Now it is not as separated. So many part of India is widely using theranostics. Asking about an alternative route of administration apart from oral route. In case of oral is showing harmful oral effects. So we'll discuss about side effect and alternatives in the fourth lecture. Please go through the brochure of our, the main course, so that you will be having the idea what is inside the sessions. Do not rush everything, because we cannot complete everything in one take, right? So we are having side effects, case studies to discuss. Cold kits. What are cold kits? So cold kits of this particularly radiopharmaceuticals are considered as a non-radioactive preparations, okay, which is doesn't have the radioactive form. So when it is combined with the radionucleotide solutions, or some produce radiopharmaceutical later for the medical imaging. So the components are being used, but it is non-radiopharmaceuticals. Okay, so that is under cold kits. Yes, we are discussing the role of clinical pharmacists. How can I forget that? How the B.Pharm graduate can find out outer opportunity. As I know, inside the slide, if you have the attention, I mentioned the pharmacist role, that is, to make certain kind of radiopharmaceutical preparation. That the designation which is given is a radiopharmacist. So yes, there are chances of B.Pharm graduate as well in the radiopharmaceutical handling. Yes, we need to maintain temperature along with it, right? Okay, so I hope today's lecture is fruitful enough, and see you guys again tomorrow. Thank you. Thank you for joining. Thank you.